Today's ICD-10 quick coding tip focuses on what you need to know about coding a cerebral vascular accident, commonly referred to as a stroke. My name is Claire and I'm an inpatient coding auditor. In my quick tips and tricks videos, you'll discover valuable insights to help sharpen your medical coding skills and code with confidence. If that sounds like something that would be helpful to you, please consider hitting that subscribe button so that you can be notified whenever I release new content. A cerebral vascular accident, commonly known as a stroke, occurs when blood flow to the brain is blocked or there's sudden bleeding in the brain. When coding a cerebral vascular accident, you'll need to identify from the medical record documentation the type of stroke. CVAs can be categorized into two main types, ischemic or hemorrhagic. Ischemic strokes are the most common type, occurring when a blood vessel supplying the brain becomes blocked. The other type is a hemorrhagic stroke, which happens when a blood vessel in the skull or brain ruptures or leaks, causing bleeding. Sometimes the medical record documentation will lack specificity regarding the type of cerebral vascular accident. When a diagnosis is simply stated as cerebral vascular accident, CVA, or stroke without additional detail, assign code I639 for cerebral infarction unspecified. An ischemic stroke is coded based on the type of material causing the blockage and the vessel where the blood flow is obstructed. The vessel can be obstructed by either fatty buildup, known as plaque, also referred to as atherosclerosis, or by a blood clot. Clots are categorized either as a thrombosis or an embolism. A thrombosis occurs when a blood clot forms in the affected vessel, while an embolism forms elsewhere, breaks loose, and travels to the affected vessel. If the physician has not specified the specific location of the occlusion, it is okay to refer to imaging reports to determine the location so that a more specific code can be assigned. It's important not to assume that a cerebral infarction has occurred just because there is an occlusion within a vessel supplying blood to the brain. Codes for cerebral infarction should not be assigned unless cerebral infarction is clearly documented in the medical record and the physician has indicated a relationship between the infarction and the cerebral artery thrombosis, embolism, occlusion, or stenosis. For example, if the physician has simply documented that there's an occluded cerebral artery, code I669, occlusion and stenosis of unspecified cerebral artery is assigned, as opposed to if the physician has documented a cerebral vascular accident due to occluded cerebral artery, then code I6350, cerebral infarction due to unspecified occlusion or stenosis of unspecified cerebral artery, will be assigned. A hemorrhagic stroke is classified based on the location of the hemorrhage, which can be intracerebral, intracranial, or subarachnoid. When coding for an intracerebral hemorrhage, it's important to have a good understanding of the cortical and subcortical structures of the brain. Subcortical structures are located deep within the brain and include the basal ganglia, the thalamus, the hypothalamus, the amygdala, and the hippocampus, while cortical structures refer to the four lobes of the brain. Subarachnoid bleeding typically occurs when an aneurysm ruptures, and codes in this category also specify the particular vessel that is ruptured. If the physician has not specified the specific location of the bleeding, it is okay to refer to imaging reports to determine the location so that a more specific code can be assigned. Non-traumatic bleeding can also occur in the brain following a recent ischemic stroke. This can be caused by medication commonly used to treat ischemic strokes, known as TPA, or it may happen spontaneously. This is referred to as a hemorrhagic transformation or conversion. In these instances, it's important to assign codes for both the ischemic CVA and the hemorrhagic CVA. Let's look at some examples. In this first scenario, the physician has documented that the patient's exam findings were consistent with a massive acute stroke. To assign the appropriate ischemic stroke code, typically it's necessary to identify the specific type of occlusion and the artery responsible for the stroke. However, in cases where the patient's condition is too critical for a CT or an MRI, determining the type of occlusion and the affected artery may not be possible, and so the stroke will be coded as unspecified. The correct code may be found by looking up the main term infarct followed by the subterm cerebral. In this next scenario, the physician has noted that the MRI of the brain revealed multiple acute lacunar infarcts in the left hemisphere. In this case, the stroke was identified specifically as a lacunar infarction, which will guide code assignment. Lacunar infarcts are small cerebral infarctions in the deep cerebral white matter, basal ganglia, or pons. These types of infarcts are believed to occur when a small perforating artery supplying blood to the subcortical regions of the brain becomes blocked. Lacunar infarcts make up about 1/4 of all ischemic strokes. The correct code for a lacunar infarction may be found by looking up the main term infarct, followed by the subterm lacunar. Checking in the tabular, we see that lacunar infarction is an inclusion term for this code. In this next scenario, the patient has been diagnosed with a cerebrovascular accident due to a thrombosis of the right cerebellar artery. To assign the appropriate ischemic stroke code, it's necessary to identify the specific artery responsible for the stroke, as well as the type of obstruction. In this case, the affected artery has been identified as the right cerebellar artery, with the obstruction specified as a thrombus. The correct code for a CVA resulting from a thrombosis of the right cerebellar artery can be located by referencing the main term occlusion, followed by the subterm artery, then cerebellar with infarction due to, and then thrombosis. This ultimately leads to code I6334, and the small dash at the end of the code indicates that this is an incomplete code, and the full code selection will need to be made from the tabular index. In this case, the additional code specificity from the tabular index pertains to laterality, and so our final code selection indicates that the affected cerebellar artery was specifically the right cerebellar artery. Now let's try some scenarios involving hemorrhagic strokes. This patient was diagnosed with a hemorrhagic CVA. The MRI shows hemorrhage located in the parietal lobe, and in order to assign the correct code for this hemorrhagic stroke, it's necessary to identify the location of the hemorrhage. In cases where the physician has documented the presence of a hemorrhagic stroke, but not its location, we can turn to the imaging results to accurately determine the location for proper code assignment. The MRI shows the location of the bleeding within the parietal lobe, so in this case, the correct code can be located by referring to the main term hemorrhage, followed by the subterm cerebral and lobe. Checking in the tabular, we see that cerebral lobe hemorrhage is an inclusion term for this code. In this next scenario, the patient is diagnosed with a subarachnoid hemorrhage due to a ruptured basilar artery aneurysm. In order to assign the correct code for this hemorrhagic stroke, it's necessary to identify the location of the hemorrhage, which in this case is clearly stated in the diagnostic statement as subarachnoid, coming from the basilar artery. The correct code can be located by referring to the main term hemorrhage, followed by the subterm intracranial, followed by subarachnoid, followed by intracranial, followed by basilar. In this last scenario, the discharge summary states that the patient's MRI confirmed an acute infarct caused by an obstruction in the distribution of the left posterior cerebral artery with petechial hemorrhagic conversion of the acute infarct in the thalamus. This indicates that the patient experienced an acute ischemic CVA with an associated hemorrhagic conversion. So we'll need to assign codes for both the ischemic CVA and the hemorrhagic CVA. To assign the appropriate ischemic stroke code, it's necessary to identify the specific artery responsible for the stroke as well as the type of obstruction. In this case, the affected artery is the left posterior cerebral artery, and the type of obstruction has not been specified. To locate the correct code for the ischemic stroke, refer to the main term occlusion, followed by the subterm artery, then cerebral, then posterior with infarction, and be sure to consult the tabular for laterality. Selecting the code for the left artery. Next, in order to assign the correct code for the hemorrhagic conversion, it's necessary to identify the location of the hemorrhage, which in this case is noted as the thalamus. The thalamus is a subcortical structure, so the correct code may be located by referring to the main term hemorrhage, followed by the subterm subcortical. So that's it for today's quick tip. I really hope that this video was helpful for you. If it was, please give it a thumbs up and hit that subscribe button so that you can be notified whenever I release new content. If there's any topics that you'd like me to cover, just leave a comment below and I'll add them to my list. Thanks for watching, and until next time, happy coding!